Hello, everyone, and a warm welcome to today's edition of Pathcast. Today is June 11th. It's a Wednesday, 2025, and I'm Rifat Manan in California. Today, we are very delighted to welcome Dr. Christofer Juhlin, who is a renowned endocrine pathologist, and currently he works as an associate professor of experimental pathology at Karolinska Institute in Sweden. And he has done a lot of research on endocrine pathology, not just adrenals. And today he is going to talk on adrenal pathology, particularly focusing on adrenal cortex, as he is going to tell you soon. And the title of his talk is Adrenal Chronicles from Slides to Sequencing. As you can see that he is going to cover molecular details as well. And as always, for our speakers and for our viewers, so please feel free to post your comments on YouTube and Facebook chat windows, and Dr. Juhlin is going to answer them towards the end of the session. And thank you again, Dr. Juhlin, for joining us today. Over to you now.
Thank you so much, Dr. Manan. It's of course, a pleasure to be here and give this lecture. I've been following Pathcast for a long time, and so does many in my institution. So it's a well-known platform, which is also, it serves as a great education tool, basically, for all pathologists. So I'm really happy to contribute back to you. And in doing so, I would like to, for 45 minutes or so, talk about adrenal cortical lesions. I will focus mostly on adrenal cortical lesions because they are most common and they are, at least in my opinion, most fun to diagnose. And there's some associations to the underlying molecular phenotypes that I would like to go into. So the title of my talk is Adrenal Chronicles from Slides to Sequencing, and you can guess that I'm going to try to merge morphology with genotypes, which is something that is fairly common in endocrine tumors, that you would like to see these genotype-phenotype correlations, and we do have molecular and morphological clues to do so. So with that said, I'm going to start my lecture, and I'm going to turn off my camera so you can focus on 100% on the slides, of course. So I have no disclosures, and all figures that I will present here are my own unless I specify that in down below. The disposition of today will be, first of all, we're going to dwell into the aldosterone-producing lesions, followed by cortisol-producing lesions, and then, of course, the most difficult distinction, which is also the most clinically relevant one, I would say. It's the distinction between adenoma and carcinoma, and how we can go about in facilitating this, which is, of course, extremely important from a clinical perspective, since one is a benign entity and one is a entity with a very poor prognosis and limited treatment algorithms. And of course, room for some questions. I will not go into adrenal paraganglioma, or as they're more known as pheochromocytoma. I will not talk about neuronal tumors, myelolipoma, and metastasis and stuff like that. So maybe we can cover that in the future. But for now, we're going to focus on the cortical lesions. So with that said, this is a picture from Wikipedia, and I think it's really good because it really summarizes what's most important to know about adrenal tumors from a pathology perspective. As you can see here, adrenocortical adenomas are the most common entities, followed by adrenocortical carcinomas. That's why we're going to focus this lecture on these entities. And you can see that the rest of the tumors, they don't really make up a big proportion of adrenal lesions, but they're nevertheless very important to recognize because they are mimics of other lesions and they have clinical implications if you do not diagnose them correctly, of course. So with that said, just a brief background how the adrenal layers are configured on the macroscopic and microscopic level. And when I was in med school, I was taught that there are 3 layers in the cortex, and that still holds true. But then also you were told that these layers correspond to different hormones, and this is only partially true. Nowadays, we know that the innermost cortical layer, the zona reticularis, also has cortisol production, not only androgen production, as you were taught in med school, most of you guys. So there is some dynamic evolution in terms of what layer produces what hormone, but even so, the distinction between the different layers is important to recognize. So this is a histological slide of a normal adrenal, beautiful with all the zonation well preserved, and you can see the layers in low power microscopy, the adrenal medulla in the center, and then reticularis, fasciculata, and the glomerulosa. And some of these layers, if they are expanded in a pathological way, this could really tell you something about the underlying biochemistry of the patient. And I'm going to get back to that in a while. So anyway, you can clearly see the zonation here with the different layers, also on high power, of course. The leading cause of secondary hypertension is primary hyperaldosteronism, or PA. I would try to call it PA to speed up things. PA is mediated by aldosterone overproduction, and this is caused by a single aldosterone-producing adenoma or multiple aldosterone-producing nodules, which are also microtumors developing independently with their own somatic mutations. And it's really important to distinguish between these two entities, because what we know is that the aldosterone-producing adenoma, it's a unilateral disease which is curable by surgery, whereas the aldosterone-producing nodules and micronodules, we think they're often bilateral. So they carry a 50% recurrence rate biochemically on the contralateral adrenal. So surgery can be, you can try surgery to alleviate the symptoms, but 50% of the patients will relapse with PA on the other adrenal. And of course, these patients, they exhibit hypernatremia and hypokalemia based on this aldosterone overproduction. So with that said, when you confirm a diagnosis of PA in the clinic, most centers rely heavily on adrenal venous sampling, meaning that you would like to locate the adrenal from which the excess aldosterone is secreted. And once you have performed an adrenal venous sampling, you can then verify unilateral PA from bilateral PA, and you can then go and suggest unilateral adrenalectomy to cure the patient. Whereas bilateral PA is usually treated by medical treatment, not surgery. But again, this is an area of discussion. I'm not going to go into detail, but there are other surgical techniques used in which you can do a 1.5 adrenalectomy and other variants and techniques, which I'm not going to go into detail about today, but this field is evolving rapidly. So, can we use morphology and functionality as a good fit for a PA? Well, we really can't. There's no way. I would never go back to morphology once I know the value of functional immunohistochemistry, which I'm going to talk about soon. So there is a lack of correlate between morphology and the functional status of cortical nodules. So if you look at an adrenal with multiple nodules, I would say there's no way you could know with certainty whether or not this produces a hormone or not. And you cannot distinguish between aldosterone-producing and cortisol-producing nodules by morphology alone. So given what I said about the zonation previously, the world is not that simply aligned that adrenal cortical adenomas producing aldosterone look very similar to the zona glomerulosa of the normal adrenal, and adenomas that produce cortisol look like the zona fasciculata. This is not the case. Unfortunately, it would be much easier. So you need to dig into functional immunohistochemistry. It's the way to go forward. So functional immunohistochemistry, basically several papers led to the publication in JCM a few years back in a consensus statement in which several authors studied a cohort of primary aldosteronism cases. What they did was they stained several adrenals for CYP11B2, and CYP11B2 is also known as aldosterone synthase, and it's expressed in aldosterone-producing lesions and also in some areas of this normal zona glomerulosa. So the use of immunostaining for CYP11B2 in these lesions changed the original morphology-driven diagnosis in 14% of cases using consensus statement and by very renowned pathologists used to diagnosing PA. So without morphology and with immunohistochemistry, 14% of cases changed diagnosis. And the authors, they designed decided to call this classic histology or non-classic histology, in which classic histology is a solitary nodule with CYP11B2 immunoactivity. These patients were cured in more than 95% of cases, which is really good to know. Whereas cases with non-classic histology, which is basically numerous nodules with CYP11B2 immunoactivity, suggest multiple nodules or a diffuse hyperplasia, which is endowed with almost 50% recurrence rate on the contralateral adrenal. So this was the first consensus study using this marker, which also led to the implementation of this marker in the WHO classification of endocrine tumors. We also had previous experience. I'm just going to briefly mention that we stained several cases in a previous study in Sweden with using this antibody. This was before the consensus statement was made. We altered the diagnosis in almost 1/3 of cases. So using morphology and then by using immunohistochemistry, we changed our mind in almost 1/3 of the patients, and it correlated much better to a surgical cure than when using morphology alone. So basically, this is the way forward. In other words, the Histological classification scheme is basically allows the pathologist to distinguish between classic histology, which is one nodule producing this hormone, usually cured by surgery, and trying to distinguish it from multiple aldosterone-producing nodules or micronodules in which the patient usually recur. So this is a very important clinical distinction, because if you have an adenoma and you call up an adenoma on post-adrenalectomy, the patient is usually, at least at Karolinska, not followed, but instead released as an outpatient to the primary health care centers to be followed. Whereas a patient with multiple aldosterone-producing nodules or micronodules will be followed because relapse is so common. So I'm going to illustrate this with a historical case with a 20 millimeter nodule in a patient with PA. This is the right adrenal. You can see one nodule clearly. This is expanding the normal cortex. So this is clearly a pathological nodule. But there were also additional nodules when we grossed this adrenal. And by morphology alone, they look very similar. They are composed of clear cells, vacuolated cytoplasm, no atypia. It looks like pathological expansions of the entire cortical layer, basically. So in 2010, we said this is the previously known entity, adrenocortical hyperplasia, which would now correspond to multiple aldosterone-producing nodules. However, with this information in hand, the endocrinologist is forced to follow this patient for relapses on the contralateral adrenal. However, with the use of CYP11B2, which was retrospectively applied on this case, you could see that the main lesion that I showed you first is stained for CYP11B2, whereas the remaining nodules are negative for CYP11B2, meaning that there's only one nodule producing this enzyme or this hormone. This is in fact an aldosterone-producing adenoma with background activity, which we call sporadic adrenocortical nodular disease. So the endocrinologist can easily say the patient is most likely cured. So this is a game changer in adrenal pathology. So, and we've had this antibody up and running a few years now, and I cannot see that we will ever go back. It is truly a magnificent help also for consult cases from outside of our hospital in centers that doesn't have this antibody up and running at the moment. And there's also the other way around. This is an adrenal with one big nodule, as you can see in the center. Looked fairly suspicious to me. But when we stained additional nodules that I did not, some of them you might suggest from the H&E, but some you wouldn't. So this is in fact multiple aldosterone-producing nodules and micronodules. This patient has a risk of relapse. So to call this an adenoma would not have made sense to the follow-up of this patient. So basically, what we have here is aldosterone-producing adenoma is a benign entity measuring more or equal to 1 centimeter. It's a solitary lesion. And it may, as I mentioned earlier, be composed of either clear cells, zona fasciculata-like cells, or compact eosinophilic cells looking more like the zona reticularis layer. So it's a mix, and by morphology alone, there's no way you can tell, at least not from my experience. These lesions, the adenomas, which is the most common form of all adrenal tumors, the adrenocortical adenoma, if they produce aldosterone, you can be fairly sure that they have a mutation in one out of several ion channels that will drive depolarization of the zona glomerulosa cell, which leads to aldosterone production and proliferation. And I will show you in a slide how that might look, basically. So these cases, adrenocortical adenomas, are most often sporadic, but there are familiar forms as well, and they are autosomal dominant, so they usually have a parent and a grandparent with the same disease, and it's early onset hypertension with hyperaldosteronism, so they're quite young when they are diagnosed, and they follow this autosomal dominant pattern. And they have constitutional mutations in the same genes that I discussed earlier, the ion channels. So I'm just going to show you how that looks. This is on the grossing table, of course. This is a solitary nodule, aldosterone-producing adenoma with a yellowish, canary yellow, tan cut surface, solid, no necrosis, no expansion, of course, nothing that would be worrisome for malignancy. And most importantly, there are no other macroscopic nodules that would suggest multiple aldosterone-producing nodules. So there's only one lesion here. And on microscopy, you see a well-circumscribed lesion, flat to no atypia at all. The cells are usually vacuolized with a lot of lipid accumulation in the cytoplasm due to their hormone production status, of course, and then the nuclei are fairly inconspicuous with no mitotic activity, low Ki67 index. There is, of course, no vascular invasion, capsular invasion. These are entities or parameters that you see in adrenocortical carcinomas, and I'm going to get back to how we differ between these two entities. So again, the power of immunohistochemistry, you can see now that morphology alone doesn't really tell us much, but with the addition of CYP11B2 or aldosterone synthase immunohistochemistry, you can clearly see that this is a positive stain, which is indicative of an adrenocortical adenoma with aldosterone production. This is also a PA patient with the only nodule visualized during grossing. Is this an adrenocortical adenoma? Sure looks like it. You see these cord-like projections of tumor cells, and you see the normal adrenomedulla. There's no expansion outside here. It's a clear limitation of this nodule. Cord-like growth, and there's no cellular atypia whatsoever. Looks fine for an adenoma to me. And so you have to really weigh in the morphology in addition to the immunohistochemistry. So I told you previously, this is an ion channel disease. There are mutations in various ion channels at the level of the membrane in the zona glomerulosa cells that will cause depolarization and will cause either influx of sodium or calcium through the ion channels, which will then lead to depolarization and hormone production. There are also mutations in other types of channels that will impede the leakage of other types of cations into the extracellular space, which will cause depolarization that way. And they're all monoclonal tumors in this way, even the small aldosterone-producing nodules that I showed you earlier. So how does this work? Or what does it really mean to us? Well, this is from a recent review article. You can see in the normal zona glomerulosa resting state, there is no activity in the CYP11B2 transcription. There is no proliferation, and the cell is in a hyperpolarized state. Whereas when renin and angiotensin activates and binds to the angiotensin 2 receptor, this will cause a conformational change in one of the ion channels called KCNG5, which will lead to depolarization through opening of voltage-gated calcium channels. So depolarization is the way to go if you want to activate the cell cycle and produce aldosterone in the zona glomerulosa. So if you have a mutation in any of these ion channels. This will mimic the physiological response of angiotensin II. So the mutations will cause a conformational change which will either keep some of these membrane bound ion channels open or closed, depending on whether it's an influx or efflux of these cations, which will either way lead to depolarization. So it's quite a neat way to show how these mutations cause tumors and aldosterone hypersecretion. And as I said, some of these voltage-gated calcium channels and potassium channels might be germline mutated in familial forms of this disease. So with that said, I'm going to go into the cortisol-producing lesions, and we can divide them into the most common forms, which are adrenocortical adenoma, of course, and then adrenocortical carcinoma and adrenocortical nodular disease. If you want to look at it in detail, and this is a very busy slide, and I'm sorry for that, but what you really need to know here is that there are forms of bilateral nodular cortical disease with cortisol production, which are heavily associated to germline involvement. So if there's only one thing I want you to remember from this lecture of today is that if you have a patient with Cushing syndrome or hypercortisolism and bilateral micronodular disease, you should always think that this might be a pathogenic germline variant. And you don't have to remember the genes, but this is heavily hereditary in this aspect. But you can divide cortisol-producing lesions into sporadic nodular adrenocortical disease, which is usually non-functional, sometimes cortisol-producing, but mostly non-functional disorder, which mimics the other lesions, in that you have solitary or multifocal nodules, usually small, and they are very hard to distinguish from adrenocortical adenomas, less than 1 centimeter. But it's of limited clinical relevance. To me, it's more or less a differential diagnosis to all the other more important entities that we see on this slide. What's important to know is that if you have an adrenocortical disease that is bilateral and cortisol producing, it can be either micronodular or macronodular. And the micronodular, the nodules are measuring less than 1 centimeter. It's usually found in younger patients with bilateral involvement. And it can be further subdivided into primary pigmented nodular adrenocortical disease, which is associated to a hereditary condition called Carney complex. There's also an additional variant, which is more or less the same, but without the pigmentation that is you see in primary pigmented nodular adrenocortical disease. And this one is called IMAD, or isolated micronodular adrenocortical disease. Again, heavily associated to germline variants in the protein kinase A pathway. If you have bilateral macronodular adrenocortical disease, usually this is evident already at the stage of imaging because they have multiple large nodules on both adrenals. These patients usually have germline mutations in 4 genes, which I have listed below, which are also important to know because this could be the first manifestation of hereditary disease, more or less. So this is a cortisol-producing adrenocortical adenoma. Sometimes the grossing is a bit different from aldosterone-producing adenomas. It could be more of an orange or tan feel to the entire lesion, but other than that, it's well circumscribed. There is no evidence of necrosis and there's no funny business going on at the periphery here. There's no capsular invasion or any nodules, satellite nodules on the outside here, as you would see perhaps in an adrenocortical carcinoma. So again, on histology, you can see a mix between these compact cells, eosinophilic, and the lipid-rich cells. Again, there's no correlation to functionality whatsoever. So you can clearly see that you can have a lesion looking like this and producing either nothing, being non-functional, it can produce aldosterone, or it can produce cortisol. So there's no way you can really tell them apart by just looking at them on H&E. Again, high power magnification. You can see the brisk contrast between the lipid-rich cells and the eosinophilic cells in various proportions. But again, very little or no atypia, no mitotic activity, or very little mitotic activity. What's interesting to know is that when you have a cortisol-producing lesion or several cortical-producing lesions, that would lead to a inhibition of ACTH at the pituitary level. Again, that would lead to a cortical atrophy of the normal, adjacent normal cortex. So what that really means is that the cortical layers are usually less than 2 millimeters in thickness, and the zona reticularis is the layer that will diminish. So again, there's not a clear-cut correlation between the layers and the hormone production. So the zona reticularis is the one that is reduced in when you don't have an ACTH um, stimulation. So that's the cortical atrophy. So a cortical atrophy is a clue that the lesion you're looking at might be producing cortisol, or the cortisol production can come from the contralateral adrenal, which might be still in the patient, of course. So again, on the genetic level, I'm just going to show you briefly that the physiological regulation of cortisol synthesis is mediated through the protein kinase A pathway, which is then, of course, stimulated by ACTH, the hormone from the pituitary, leading to a downstream event in which PKA protein kinase A is activated. However, similarly to aldosterone-producing lesions, activating mutations in this pathway, the protein kinase A pathway, or deactivating mutations in inhibitors of this pathway will lead to similar activation of PKA, which will lead to proliferation and cortisol synthesis. So some of these gene mutations are somatic for sporadic adenomas and so forth, and some are germline, as we talked about previously within in the bilateral micro and macronodular adrenocortical disease states. One special form, which I briefly mentioned, which is a form of micronodular bilateral disease, is the primary pigmented adrenocortical disease. And this is coupled to Carney complex, which is an advanced syndrome in which you can have a various degree of manifestation of cardiac myxomas and hyperpigmentation and endocrine overactivity in various organs. The specifics of this entity is that you will have multiple eosinophilic nodules with clear-cut pigmentation, and you will have atrophy of the adrenal cortex between these nodules. And it's always bilateral, and it's always in young adults or in children. So, and here is a case on the low power level. You can clearly see these multiple, almost kissing nodules with the eosinophilic appearance. And if you go into high power, you can clearly see that they have a clear-cut pigmentation. Be aware, though, that there are other times when adrenocortical adenomas as well might exhibit hyperpigmentation due to accumulation of lipofuscin and other pigments. But this is not the case. If you have a bilateral involvement in young adults with a Cushing syndrome, hypercortisolism, you're more prone to diagnose these as primary pigmented. So this is an entity that, of course, requires you to be on the look for this pigmentation and the internodular atrophy, which is characteristic of this disease. Again, high power showing the intense pigmentation of the eosinophilic cells. Here's CYP11B1 for the same case. CYP11B1, which is the hormone that catalyzes the production of cortisol. It's not CYP11B2, so they're fairly similar in terminology, but it's a different enzyme. You can clearly see that these eosinophilic cells produce cortisol, which is also part of the disease entity, of course. This is a bilateral macronodular adrenocortical disease. Again, by the name, you would know that by looking at it on the grossing table, you can see the macroscopic nodules. And this is, of course, always bilateral, more or less, and the patients are usually associated to hypercortisolism. In this case, one adrenal was removed, and you can see that the cut surface is extremely multinodular, with the different areas showing various appearance here, all the way from tan to clear-cut yellow. And on the histology level, this normal zonation is completely abolished, and there is numerous kissing macronodular, benign-looking nodules here that all produce cortisol to some extent. And as I told you earlier, these lesions have been associated to various germline mutations in specific genes, and this is a quite old publication from a French group in which they saw that the patients with bilateral macronodular adrenocortical disease had germline mutations in a gene called ARMC5, and they beautifully showed that if they sequenced DNA from each of the other nodules that they found from these patients, they had different alterations on the remaining allele. So you can have loss of heterozygosity or additional somatic mutations in different sites for all of these lesions. So they're all independent monoclonal tumors developing more or less synchronously in these patients. So that was a beautiful study in which you show the pathogenicity of ARMC5. So again, my take-home message for the adrenocortical nodules with cortisol production, when you face them in the clinic, always suspect bilateral disease and always suspect germline predisposition. And you can't go wrong from there, basically. Okay, now to the most, I think, important part of my lecture in terms of why we need to distinguish benign from malignant. This is, of course, extremely clinically important because adrenocortical carcinoma is a lethal disease with poor prognosis, a limited response to conventional therapy. The conventional therapies are very limited. So unfortunately, once disseminated, these patients do fairly ill. So these tumors are, I would say 50% of them are non-producing. So they are just discovered as an incidental mass of the adrenal or an abdominal mass, or 50% of them are hormone producing, and they are usually cortisol producing or cortisol and androgen producing, meaning that they will show symptoms of virilization in females and also signs of Cushing disease. Cushing syndrome in both male and female patients. So as I said, it's a rare but lethal tumor, and it's usually sporadic in adults, but it's very often, very often associated with germline disease, Li-Fraumeni syndrome being the leading cause in the pediatric setting. So a pediatric patient with adrenocortical carcinoma is by default germline involvement is suspected or must be excluded in any way. We subtype ACCs from a histological level based on the characteristic morphological features. We have conventional, oncocytic, myxoid, and sarcomatoid. And there is no real clinical distinction. It's not prognostically relevant, but it's might give some diagnostic difficulties because some of these lesions might mimic metastasis from other organs, from tumors from other organs, making the diagnosis not as straightforward as it would be with a conventional ACC, for example. So I will go into detail later on when I discuss the scoring algorithms for how we try to separate adenomas from carcinomas and how they might be affected by subtyping as well. So adrenocortical carcinoma, usually a solid mass. The cells are usually seen in sheets or in solid areas like this. Some, like this one, has very little nuclear atypia, which is surprising because most of them do exhibit pleomorphism to a certain degree, but they are also quite monomorphic in some areas. Geographic necrosis, as seen here, is an important part of adrenocortical carcinoma, and it's rarely seen in adenoma. So which I'm going to get back to later, but in the scoring algorithms in which you try to separate adenoma from carcinoma, necrosis is almost always a parameter that will yield points in terms of malignancy. So look out for geographic necrosis. And bear in mind that necrosis can be very geographical. It can be very regional as well. I've seen a case at the ECP by my good friend Dr. Oscar Mitti in Toronto. He showed a adrenocortical tumor, and the area with atypia, increased mitotic activity, and necrosis was very regional. So you have to be careful and sample the entire lot of this tumor and really look for these areas, because it has been shown that they could be very heterogeneous in this aspect. And some of these lesions are 10, 11 centimeters. So you can imagine the amount of slides that you have to go through to properly visualize these areas. So Be careful, these features might be regional and not entirely global. Increased mitotic index is a feature of adrenocortical carcinoma. Usually adenomas have a very low mitotic count, whereas carcinomas usually have more than 5 mitotic figures per 50 HPFs. So, and they might be also atypical. The mitosis, tripolar mitosis, are not that uncommon actually. So again, you have to count over a really large area. So it's time consuming, but it's also worth it, of course, for the patients in the end. We sometimes, or not sometimes, we more or less regularly also use phosphohistone H3 immunohistochemistry, which is a marker for mitosis. Again, we are trying to establish whether or not this can replace the original mitotic counting. As of now, we use it as a marker to look for the area of the highest mitotic activity using phosphohistone H3, and then we score regularly on H&E. But to me, it's a great assistance because I really find this marker valuable in adrenocortical carcinoma. Adrenocortical carcinoma show areas of invasion through the tumor capsule in the periphery, and the tumor tissue might extend out in the extraadrenal space and also into the blood vessels, of course, which is a feature that you do not see in adenoma. Vascular invasion, be careful for floaters. In the left picture here, I would say this could be contamination because there is no fibrin cloth associated to this tumor deposit. So manipulation of the tumor might actually cause tumor to contaminate the vessel lumen. So be careful. You should always look for the associated fibrin cloth as a sign of in vivo activity before you call VI, more or less, in this tumor type. Showing you one oncocytic and one myxoid adrenocortical carcinoma just to show that there are specific features associated to these subtypes. Although not clinical in significance, the oncocytic subtype is almost always solid, and of course these cells are per definition eosinophilic, which is a parameter that will give you a point towards malignancy using the Weiss criteria. That's why there is a specific algorithm if you want to assess the malignant potential of oncocytic adrenocortical tumors. On the right, you see the myxoid adrenocortical carcinoma, which might give rise to differential diagnostic difficulties, as the mucin might trick the pathologist into actually look for a metastasis from another organ. And this is especially complicated if the patient already has a diagnosis of adenocarcinoma or similar from another organ in the history, of course. 10 minutes to go, and we're getting close to the most pressing point of diagnosing adrenocortical lesions. The histological algorithms, as I already mentioned, there's no clear-cut way to tell the adenoma from a carcinoma apart with just one morphological or cytological parameter. There's not one molecular or immunohistochemical marker that would separate them. Unfortunately, we thought so when we started doing research with molecular, but this is not the case. So it's more advanced than we thought, as always. So basically, we're stuck with different histological multi-parameter algorithm to secure the diagnosis of adrenocortical carcinoma. And the WHO classification of 2022 for endocrine tumors recommend the Weiss, Reticulin, Helsinki algorithms for ACC. Whereas the Lin-Weiss-Bishiglia algorithm is reserved for oncocytic tumors to separate oncocytic adenoma from oncocytic carcinoma. And then there is a fifth algorithm called the Weinicke algorithm, or the AFib algorithm, used to score pediatric tumors because they might behave very differently. And this is not the topic of this lecture. I'm focusing mostly on adult adrenocortical lesions. So the Weiss criteria, most of you who diagnose adrenocortical tumors know this by heart. You need 3 out of 9 histological parameters to diagnose ACC. There is no immunohistochemistry, there's no genetics, there's only morphology and histological parameters here. So you can clearly see that they put a lot of effort in the proliferation grade through the mitotic index and the presence of atypical mitosis and also necrosis. But again, also vascular, capsular or sinusoidal invasion are also important parameters, which will also give you a point towards the diagnosis of ACC. The reticulin algorithm is much younger, and it works as follows. You need to perform a Gordon-Sweet silver histochemical stain to visualize the reticulin network of the adrenocortical tumor. And if this network is aberrant or altered or expanded, which is not seen in adenoma, then the suspicion of carcinoma will lead you to associate this finding to one of the following parameters. You need increased mitotic rate, tumor necrosis, and/or vascular invasion, I mean angioinvasion. If you have an altered reticulin network and one of those 3 parameters, the reticulin algorithm would support the diagnosis of ACC. And this is an adrenocortical adenoma stained for reticulin. You can clearly see that the network is fine, delicate, and the lobules are separated in a nice meshwork, which is clearly not the case in this adrenocortical carcinoma, in which you have expanded lobules of tumor formation and a loss of this fine meshwork that we saw in the previous picture. So also not shown here is the Helsinki algorithm, which is sort of a favorite of mine because you need to use the Ki67 labeling index, and I think that makes biological sense to use Ki67 as a diagnostic marker because highly proliferating adrenocortical tumors with a high Ki67 index are usually adrenocortical carcinomas, even though rarely we can see adenomas with fairly high Ki67 indexes. So if you combine the Ki67 index with some toxic parameters that we discussed previously, the Helsinki algorithm with fair confidence can identify adrenocortical carcinoma. When you have diagnosed a carcinoma, you need to grade this tumor. And you need to grade it by the mitotic rates because this has prognostic significance. We can see that low-grade carcinomas are less prone to metastasis and death by disease, whereas high-grade carcinomas have a much higher risk of death of disease. And this is purely based on how you count the mitosis. So it correlates fairly well to prognosis in this aspect. Finally, a few words on immunohistochemistry. Well, of course, sometimes you need immunohistochemistry to verify that this is an adrenocortical tumor. So there are numerous markers that you could use to highlight the adrenocortical cell, whereas I would say SF1, steroidogenic factor 1 is the most specific and most reliable one because all the remaining adrenocortical markers are not very specific, as you know. They might be seen in other tumor types, and some of them are also found in other tumor types within the adrenal. So be careful to use synaptophysin as the only marker of adrenocortical differentiation. If you have a non-producing cortical tumor and you stain it for synaptophysin, and it's positive, you cannot just go ahead and call it adrenocortical tumor because I've seen cases by consults in which this was a misdiagnosed pheochromocytoma. Keratin is not a reliable marker. Alpha inhibin, calretinin, melanase are of course used even in our clinic, but be aware that there are numerous tumor types that might metastasize to the adrenal that will carry immune expression of one or several of these markers. So just to show you how this might look like, this is an adrenocortical carcinoma with a diffuse expression of synaptophysin, SF1, calretinin, melanase, and also p53, which I regularly use because this is a marker of underlying TP53 mutation. And you can also see the Ki67 labeling index was very high, which was also supportive of an ACC diagnosis. And well, I mean, you would always wonder, Are there not any genetic differences between these entities, adenoma and carcinoma, that would help us to distinguish this malignant tumor from the benign one? I would say there are. There are several papers showing on a global genome-wide level, there are many differences, but there's none that's easily translatable into clinical practice. So even though adrenocortical carcinoma usually show aberrant IGF-2 signaling, beta-catenin activation, and aberrant p53 staining and mutation, also has a different landscape in terms of chromosomal aberrations and methylation compared to adenoma, there's not a single marker that we could use with confidence to rule in or out adrenocortical carcinoma, unfortunately, at this point. And once you have diagnosed an ACC, there are, on the pangenomic level, certain risk clusters, depending on what type of mutations you have, what type of methylation patterns you have, what type of expressional cluster you adhere to, you would have a better or worse prognosis. However, again, as you can see, global methylation, global chromosomal analysis are not really clinically relevant, at least not at Karolinska at the moment. We're happy if we can offer a single gene analysis or maybe a panel for NGS testing, but to do expressional clustering and global methylation profiles, it's a thing of the future. So we're stuck with classical parameters like grading them using the mitotic index, and also, of course, the TNM and clinical workup of these lesions. But again, some of these markers might be implemented in the future, and there are ongoing research now trying to simplify these multi-omics profile to make a more clinically useful panel to be used for our patients. I use immunohistochemistry as a surrogate for these fancy molecular techniques. I use p53 staining, of course, which might help detect the p53 mutation, which in turn can be somatic or germline. The p53 mutation is in itself coupled to worse prognosis. If you have an ACC with a p53 mutation, the patients do worse than if they don't. The same is true for CTNNB1, beta-catenin. If you have that mutation, of course, you will have a nuclear accumulation of the antigen. So I stain for beta-catenin, and again, this is an indicator of worse prognosis. And many labs also enjoy IGF-2, in which overexpression of IGF-2 is associated to ACC and very rarely seen in ACA. So this is also a marker that some labs are really enjoying in terms of when they diagnose. It's not diagnostic per se, but it's clear cut that it suggests a carcinoma. So it works in favor for a carcinoma if you see IGF-2 expression in any type of adrenocortical lesion. This is an IGF-2 staining, again from Dr. Miti at Toronto. In an ACC, you can see that there's a perinuclear accumulation of this antigen, which is not seen in adenoma. Finally, just a few words on hereditary syndromes. As I told you in the beginning, if you have a pediatric patient with ACC, the chance or risk is very high that this is a Li-Fraumeni syndromic patient. So, and given the rarity of adrenocortical carcinoma, I would say that all patients with this disease needs to be subjected to germline investigation, because the rate of germline involvement is quite high. And it's not only the Li-Fraumeni syndrome, it's also Lynch, MEN1, FAP, Carney complex, and so forth. So in total, many patients with ACC do in fact have a undiagnosed syndrome or a known syndrome. But if it's undiagnosed, the pathologist could be the one to suggest it based on these different immunohistochemical stains that we can do. So I regularly perform MMR protein status for adrenocortical carcinoma because I think it's important to know whether or not it's mismatch repair deficient, which will also imply Lynch syndrome, especially if the patient is young. Some final remarks. Always, if you can, and if you have access to this wonderful antibody, which is CYP11B2, use functional immunohistochemistry for aldosterone-producing lesions. If you have multiple cortical nodules, always suspect bilateral involvement and germline predisposition. So suggest that. In the tumor board, if you can, use multi-parameter algorithms to secure the ACC diagnosis. And remember that molecular and immunohistochemistry may help, but it's not really diagnostic. So we're still stuck with morphology for most aspects when we diagnose ACC in the clinical context. So with that said, I wanted to thank Dr. Manon for having me for this lecture. I hope it was fruitful to you, and you'll probably, hopefully, you learned something. And let's keep in touch. Here's my email, my Twitter account, and also hopefully we might see some of you at the USCAP in 2026. If not, you stopping by in Stockholm anytime soon. Thank you so much.
Thank you so much, Dr. Juhlin. This was really wonderful to have you and to deliver this talk on adrenal cortical lesions. And I have quite a few questions online from our viewers. Let me ask them quickly. So one of our colleague who is a practicing endocrine pathologist in New Delhi, Dr. Shipra Agarwal, she has this question for you. So her question is here. So we are using CYP11B2 IAC routinely for almost a year now. The question is that what is the normal pattern for the immunostain? And another related question that we have come across pheochromocytomas and renal cell carcinoma cases in which the adjoining adrenal gland showed microscopic nodularity, and these lit up on the immunostain with history and biochemistry not akin to PA. So how to
Yeah.
interpret and manage these?
Yeah, thank you so much for this question. That's a great observation, and we have seen the same thing. Uh, Basically, if you stain any adrenal from autopsy or any type of adrenal with a non-PA condition, like a pheochromocytoma or a cortisol-producing lesion, what happens is that you will see micronodules in many of these cases. Previously, we call them aldosterone-producing cell clusters. They have now been refurnished into another entity by the Histaldo. But it's true that we see micronodules, these APCC, so very small B2 positive nodules in also normal adrenal, normal looking adrenal in patients without PA. So the question is, how do you separate adrenals with this background activity, as I call it, from a true multinodular pathological hyperaldosteronism? And this is something that we need to look into. And some preliminary data from our institution suggest that the size of the nodules might be interesting in this aspect, meaning that if you have many nodules of varying sizes with little variation, this would truly correspond to a pathological multinodularity in a PA patient. Whereas if you have a large, say 3 centimeter lesion with B2 positivity, and then you have these micronodules that are less than 1 millimeter, this is probably an adenoma with background activity. So clearly we need to know what this background activity really stands for in non-PA patients to understand what multinodularity means for a PA patient. So it's a great observation, and we really need to look into that.
Thank you again, Dr. Juhlin. She has one more question. Does IGF-2 help in the classification of borderline cases like WAIS-3?
So this is a good question. I don't use IGF-2. We don't have the tradition of using it. We've relied heavily on VICE and Ki67 and other parameters, P53, beta-catenin and stuff like that. But we never managed to set up IGF-2, which I really would like to do in the future. But due to some circumstances, we have not been able to do so. I know from personal communication with some of my endocrine pathology friends overseas that they rely heavily on IGF-2, and they're very convinced it's a good marker. And I've seen some publications supporting this, that IGF-2 is almost always associated to adrenocortical carcinoma. I would say if I have a borderline tumor in terms of VICE criteria, if you land on a score that would say that it might be carcinoma, it might be adenoma, I would probably start off with doing additional levels, embedding the entire tumor, looking for areas of necrosis that I previously didn't find, to really push it over the edge towards carcinoma, especially if it has an IGF-2 positivity. That would be my strategy.
Right. Thank you. So the next question is from another colleague of ours in Denmark, Anand Loya. So he has this question for you. Let me read it. Can you please share your experience with ZOS2 methylation in adrenocortical carcinomas?
Yeah. Uh, I have no clinical experience in GOS2 methylation. This refers to a publication by an American group led by Giordano and Gary Hammer in Michigan, in which they try to combine all these multi-omics parameters into one single analysis that would truly tell the prognosis of an ACC, which is the GOS hypermethylation. But I have not used it in the clinical aspect, and I haven't even done research on this specific topic. So I think it's extremely promising, and I hope other labs will reproduce it, but I don't think it's nowhere near clinical use in any lab that I know of yet.
Right. Thank you. So there is another question from Dr. Loya. What he wanted to know about your experience on the role of PHH3 marker in adrenocortical tumors.
Sorry, could you repeat
PHH3, if you have any experience on PHH3.
Oh, PHH3. Yeah. As I mentioned in my lecture, like I use it as a sort of like a flyover marker to know where the mitotic activity is the most intense, and then I go into the H&E area and I count that area, sort of like a hotspot technology to to look for mitosis. So we report both at Karolinska. So the tumor gets a mitotic count by PHH3 immunohistochemistry and also by morphology. They usually correlate, but not all the time, because sometimes PHH3 stain adrenocortical tumor cells, completely round cells, and not like. So I'm not really sure how to interpret that staining when it's not in the metaphase or in the telophase. I'm quite careful of over-reporting mitotic grade, but I use it as sort of like a flyover marker in this aspect.
Right. Thank you. So the next question is from another colleague of ours. The question is, does more or less chromatin opening or lack hereof play a role in the immune cells, like Swiss-Nef complex?
That was a really tricky question. So the question was if the open or closed chromatin remodeling complex has a role in adrenocortical carcinoma, or in the immune cells.
Immune
Sorry.
cells, yeah.
That I have no idea actually. I mean, there is some research going on about the immune response in adrenocortical carcinoma, but the details of it, I'm not sure. I mean, there has been some characterization of the immune landscape and also PDL1 staining and so forth that I know has been published, but I don't think the outcome of those studies have been really promising in terms of immunotherapy, and whether or not chromatin opening plays a role in the immune cells of ACC, I'm not sure.
Right. Dr. Loya has something additional to add. He says that in their experience, PHS3 is negative in FEOs. So in many cases. So what about you?
In pheochromocytomas, we use PHE3 as well. We have very little experience. I mean, I usually, this is another topic, of course, but pheochromocytoma or intraadrenal paraganglioma, they're all potentially malignant, but the metastatic potential varies a lot. So, and you have to grade that in a way, or try to appreciate the risk of future metastatic spread. And by doing so, the current algorithms that you use also include counting mitosis. So we've done in a few. I'm not sure I can recall whether or not they're all negative, but that would for sure be an interesting topic for a research paper if this is the case. But I've only seen it in a few, and I can't promise you that they were all negative, in my opinion.
Right. Our colleague who asked that question on immune cells has this additional comment that they were considering EZH2 inhibitors. So that's why that
Ah,
question came up.
yeah. Yeah, that I think that would be a question that you would need to direct to the endocrine oncology team, more or less. If this is actually, if the, I have very little experience in this in the role of ECH2 inhibitors in clinical practice of ACC. I'm sorry.
Right. Thank you. So I saw another question. Let me read that for you.
Mm?
This is about the like different like systems that are used for differentiating adenomas and carcinomas, and waste system is, I think, like very much used widely, as you mentioned. So the question that is asked is that in the evaluation of adrenal cortical tumors, how reliable is waste system in borderline cases, and are there efforts to refine or replace it with
Yeah.
molecular adjuncts?
Yeah. So I've met endocrine pathologists that do not believe in borderline cases. Like, I mean, more or less, this is a human creation. The tumor knows if it's malignant or benign. So if you end up with a borderline case on VICE, I mean, I would then submit all the remaining tissue for morphology. I would cut multiple levels. I would probably also order all the immunohistochemical stains I have and also try to do the reticulin and the Helsinki scores. I've had cases in which the VICE score has been borderline, so to speak, and then the reticulin and Helsinki algorithms pointed heavily towards ACC. So we had a discussion on tumor board, and then there were no sign of dissemination, but the patient was followed as it had a ACC. So obviously, it's not very practical to have 3 or 4 different algorithms if they point to the different diagnosis, of course. But in these borderline cases, I would strongly suggest you to look very careful for missed areas of VI, missed areas of necrosis that would push you over the edge of ACC, or on the contrary, back to adenoma. Um, so molecular adjuncts, yes, I believe that would be a thing for the future. But then again, the current NGS platforms in our clinical use are not equipped to deal with these pan-omic type of characterizations that we have found in research papers. So we need something more simple, more straightforward than what's known today.
Right. I think we are coming to an end. Couple of more questions. Like one is about Ki-67. You mentioned that you probably rely on Ki-67, and this question is about what is your approach to interpreting Ki-67 in adrenal tumors, and how much weightage do you give on it in routine
Yeah.
practice?
Well, uh, I rely heavily on Ki-67. I mean, if I have an adrenocortical tumor, and the Ki-67 index is 15%, 15%, but the VICE score, which is just an adenoma, I would be very suspicious. I would do the other algorithms. Of course, I would look for VI. I would submit their entire adrenal to look for areas that might suggest ACC, because Ki-67 to me is a great prognostic indicator and also suggestive of ACC. Uh, it happens that we stain multiple areas, meaning that we stain several slides, because we know that there might be a regional heterogeneity in the Ki-67 index. And since we're fully digitalized in Karolinska, we only do digital pathology. That means that we do digital assessment of the Ki-67 index. So I count 2,000 cells in hotspot regions using this digital platform. Again, more research is probably needed, but I think this is a way forward in borderline cases.
Right. Thank you. One last question for you, Dr. Juhlin. So the question is about how do you approach limited material on biopsy or cytology specimens, and what is your approach to that, and how can you avoid overdiagnosis or underdiagnosis?
Yeah. So basically, I would like to pinpoint that biopsies of the adrenal gland, whether or not it's a core needle biopsy or a cytology, fine needle aspiration biopsy, I think the value is to exclude metastasis to the adrenal. That's the most important part of biopsying an adrenal mass. So if you have a non-functioning adrenal mass in a patient with a known tumor, a known carcinoma, or any type of malignant lesion, fine needle aspiration biopsy has been shown to be safe and a very good method to exclude or verify a metastasis. But the distinction between adrenocortical adenoma, carcinoma, and all these different types of lesions that I showed you earlier, it's not reserved for biopsy material. So in our routine, in our department, the routine is that we only perform biopsies if we have a clear-cut suspicion of a metastasis to the adrenal gland, and we want to verify it before taking the next decision.
Right. Thank you so much. Thank you so much, Dr. Juhlin. I think that's all that we have about questions from our audience. And thanks to our audience for such engaging questions with Dr. Juhlin. And we really appreciate Dr. Juhlin for covering such a complex topic, which is so comprehensive, and our viewers are very appreciative. And you would be happy to hear that we had about 100 or more viewers who joined from different parts of the world. Oh, I think there is one last question. Maybe maybe I will add that. So
Yep.
I just saw it. So in breast cancer, it has been mentioned that a phosphohistone H3 or PHS3 is more robust than Ki-67. Does this
Mm.
correlate with your experience?
Well, the study has to be performed first. We have the data. I mean, we're accumulating data using both PHA3 and Ki-67. So the question is, do they correlate? I'm not sure they correlate in a linear fashion because we have some adrenocortical carcinomas with a high mitotic index, but the Ki-67 is not really that high, and you can see the opposite as well. So we will really need to look into this in adrenocortical tumors, whether or not PHA3 and Ki-67 has a linear correlation or not, and whether or not how you should interpret it. So as of now, I would suggest you to use PHA3 as a screening marker to look for the area in which you count mitosis by H&E at this point. But then in the future, who knows if PHA3 could be included in any of these algorithms or maybe replaced by Ki-67. We'll need to see.
Right. Thank you again. And thanks a lot to our viewers who joined from countries far away. I could see some of our viewers who mentioned that they joined from Mexico, Algeria, Libya, India, Somalia, Denmark, to name a few. And it's really heartening to see our colleagues attending these talks and learn from our experts. And we encourage you to follow Pathcast on different social media platforms like Facebook, YouTube, Instagram, and X, so that you can stay updated with our upcoming lectures. And we also have archive lectures so that you can get access to those as well. And it was a great pleasure to have you on board today, Dr. Juhlin, and we got to learn a lot from you. And definitely, we would love to have you back so that you can cover other topics, including adrenal medullary lesions and other neuro or other endocrine topics as well. Thank you so much. Thanks a lot.
Thank you so much. Thanks for having me. It was great. Thank you.
Bye-bye.
Bye.